I'm going to talk about Chem Sex and drug-drug interactions. So here you have my disclosures. So within the last 3 decades, our society has experienced big changes, and we also have seen some changes in the way how people are using drugs. In the decade of 80s, heroin was the drug most used in the streets. After that, heroin was replaced by cocaine, and now we have new drugs going on in the scene, including those used in ChemSex. ChemSex is a relatively recent phenomenon. If you search in the internet, first reports are from 2015, and after that you can see an increase in annual papers on this topic. But there was nothing before. So definition of ChemSex, there are different definitions. One of the most conservative is the use of specific drugs, specifically for sex, and mainly used for gay men and other men who have sex with men. So ChemSex is not just using drugs, but it is a specific form or recreational drug use or a sexualized drug use, also reported in the literature. So which drugs are used in ChemSex? The big three, the drugs which are included in the definition are gamma hydroxybutyrate or GHB, methamphetamine or crystal meth, and mephedrone. These are the classical three, but chemsexers normally combine these drugs with other substances including alcohol, poppers, erectile dysfunction drugs, ketamine, ecstasy, or cocaine. So, and this is it's not just the drug use, but it's in a sexualized context. So it's very common that the chemsexers use these applications to find sexual partners to do chemsex. So why are we talking about chemsex in this healthy living workshop? First, because this is a very common phenomenon. These are different survey studies, and results show that among 1/3 to half of our MSM HIV positive patients have been engaged in chemsex during recent months. And secondly, because chemsex may have negative consequences for health. It has been well recognized that chemsex is associated with higher risk for transmission of bacterial STDs, as well as with HIV and hepatitis C transmission, especially in those chemsexers using IV drugs, what they call slamming. It can be also associated with higher risk of psychosis and other psychiatric disorders. And specifically in HIV-infected patients, it has been suggested that chemsex may be associated with suboptimal treatment adherence and drug-drug interactions with higher risk of overdose. Actually, these drug interactions have been claimed as a partial contributor to the higher risk of deaths reported in recent years with drug use in chemsex. These graphs are from forensic reports, and you can see in the left panel how GHB-associated deaths have increased during, I don't know how to do it. Okay, during last years. And in the right panel, you can see also an increase with deaths associated with cocaine and other stimulants use, including mephedrone. And part of this increase in mortality has been suggested that drug interactions may have a role here. So, but what's the rationale behind this interaction? Is because some antiretroviral drugs, and I'm talking specifically about pharmacoenhancers, ritonavir, and cobicistat, may inhibit transporters and enzymes responsible of drug disposition, so they can alter pharmacokinetic of drugs used in chemsex, posing the patients at higher risk for drug interactions and increasing the risk of overdose. Which kind of information do we have about this topic? Well, although we would like to have strong evidence from clinical trials, these trials are lacking, possibly because ethical issues. Clinical reports, we always are talking about individual cases in the emergency department, et cetera, but clinical reports in the literature are not so common, probably because they are underreported due to a negative publication bias. So in absence of this clinical information, we have to go to a theoretical rationale based on in vitro data, and this is most of the information that we have. And if you go to most of the websites on drug-drug interactions and you look for interactions between Chem Sex drugs and antiretroviral drugs, they all start with the same sentence. The quality of evidence is very low. This hasn't been studied, but it's expected to. So we are just speculating. So let's speculate. And here is the rationale for potential drug interactions. In this table, you have the drugs commonly used in Chem Sex, and they are divided in two groups. You have erectile dysfunction drugs and ketamine, mainly metabolized in vitro studies by CYP3A4, the isoenzyme from the P450 system. And here you have other drugs primarily metabolized by CYP2D6, methadone, methamphetamine, GHB, or ecstasy. And here in this table, you have also more in vitro data showing the inhibitory concentration of ritonavir and cobicistat of different isoenzymes of CYP3A4. So what we can see is that both ritonavir and cobicistat are very potent inhibitors for CYP3A4. Inhibitory concentrations are very low. This is in nanomolar, so in nanogram per ml, and you can compare to clinical concentrations. So inhibitory concentrations are much lower than clinical concentrations. So at clinical dosing, we are going to get a complete blockade of CYP3A4, and as a result, we are going to have a high risk for drug-drug interactions with these drugs, erectile dysfunction agents, and ketamine. Actually, we have data, we have clinical data on these interactions. And if you see the prescribing information, for example, for ritonavir, you can see how ritonavir produces marked increases in exposure to sildenafil or vardenafil. And in ketamine, I found this paper in 2 HIV-infected patients. One was taking darunavir ritonavir, the other was taking lopinavir ritonavir, and both of them had side effects due to ketamine overdosing. But that's the evidence that we have nowadays. So let's go to the other group of drugs, those metabolized by CYP2D6. You can see that also ritonavir and cobicistat, they are also inhibitors of CYP2D6, but inhibitory concentrations are much higher. So they are weaker inhibitors of 2D6. There are reports of life-threatening overdosing in 2 patients with ecstasies and GHB. But these patients were taking, if you see the year of publication, it was late 90s, so these patients were taking ritonavir at high dose. Ritonavir was being used at 400 or 600 milligrams twice daily, which is much above the doses that we are using today. So what happens at the boosting doses? So once again, here you have inhibitory concentrations for CYP2D6, and here you have clinical concentrations. And you can see that at clinical concentrations, we are below inhibitory concentrations for these cytochromes. So the risk of interactions with these drugs, although there is a rationale, is much weaker than for CYP3A4 substrates. We don't have data on the interaction between ritonavir or cobicistat at boosting doses with these drugs used in ChemSex, but we have data with the cypramine. The cypramine is a drug which we use in pharmacology as a CYP2D6 probe. So we can extrapolate these changes to other substrates for this isoenzyme. As you can see, when healthy volunteers were given ritonavir 100 milligrams twice daily with the cypramine, we saw an increase of the cypramine of just 26%. And with cobicistat at clinical dosing, we saw an increase in the cypramine of only 60%. But I want to call your attention to the variability of these interactions. So we can have a patient with only a mild increase in the CYP2D6 substrate, only 30%, but the next one may be nearly doubling the exposure to the drug. So there is also a wide variability in this kind of interactions. These are pharmacokinetic interactions. We have a pharmacoenhancer that is altering concentrations of the drug, and the patient may be overdosed, but we also have pharmacodynamic interactions. Here we are not going to see any change in drug concentration, but we are going to see a change in the effect. And it's known that when we combine cocaine with rilpivirine, we may get a QT prolongation. Then if we combine two stimulants, the patient may be at risk for hyperthermia, dehydration, agitation, tachycardia, etc. And if we combine two depressants, the patient may be exposed to respiratory depression and coma. And this is especially true for the interaction between GHB and alcohol, which is responsible for most of emergencies visits in the emergency room because of this reason. You can see here in this table that alcohol is present in most GHB intoxication. These are different series of GHB intoxications. You can see that coexistence of other drugs is very common, but that alcohol is the most prevalent in all these intoxications. And people using GHB know very well that they cannot mix GHB with alcohol because they increase the risk for overdosing. And in a nice interaction study in healthy volunteers, this was observed. They combined GHB and ethanol in healthy volunteers. They didn't see any change in drug concentrations of any of these substances, but they measured the effect on respiratory function through the oxygen saturation in peripheral blood. And as you can see, both ethanol and GHB produce a transient decrease in oxygen saturation. But this effect was more pronounced when these two drugs were combined, increasing the risk for respiratory depression. So in conclusion, Chem Sex is common among MSM, especially if they are HIV infected. This practice may be associated with negative consequences in terms of STDs, psychiatric disorders, and overdose. Chemsexers may be exposed to higher risk for drug interactions, and this is especially true if the antiretroviral regimen includes boosters, and the drugs used are cytochrome CYP3A4 substrate. Less clear, although there is a rationale for CYP2D6 substrate. But in any case, quality of evidence is still very low. Clinical trials, as I said before, are lacking. There are alternative methods to estimate these interactions. For example, one could be simulate the clinical trials using PBPK modeling, and case reports in real life would be very welcome. In this way, I would like to introduce you this clinical website, clinicalcasesddis.com. This is an open access webpage on clinical cases on drug interactions used by people living with HIV, including recreational drugs. So you can use this page for search clinical cases, but also for report your experience with your patients if you have this situation, and to share your experience with other clinicians. And let me finish with a positive message. After an alarm showing an increase in Chem Sex from 2013 to 2016, this study recently published show a trend to a decrease in Chem Sex and in using drugs such as GHB and methamphetamine from 2015 to 2018. So hopefully we are going to go a trend towards a decrease in this practice. So thank you.